Thank you. It's very nice to present, but my point of view on the graft selection for the ACL. Just a second. I just try to share. Okay, I hope you can see it now. Okay, as we heard, we have to encounter that at least 7% of the ACLs will rupture within first 5 years, and it's even worse with the younger population because we know from the literature that under 20 of years we have the re-rupture rate something between 18 and 30%, which is very, very high. And so that makes the situation quite awkward. And we know some factors of re-rupture, that is a younger patient age, that increased activity level, which we saw also with Professor Domżalski work, that it's the activity level of the younger patients is growing. Also, the use of allografts and artificial devices makes the risk higher, which is quite obvious that the unexperienced surgeon cannot provide often a good technique. And what could sound strange, also the very large academic centers procedure are of higher risk of re-rupture. So the revision technique strictly depends on the primary technique. So it depends on the graft that was used primarily, what was the tunnel location, what was the tunnel size at the beginning and in the end, and what were the concomitant procedures. Do we have any meniscal and chondral repair? The new graft must have some new features that have to have the same strength, the same stability has to be achieved, and it has to have the ingrow potential and possibly low morbidity. So there is a still ongoing discussion if we should choose the new graft from the same knee or from the opposite knee. Graft quality is based on the size also. So we have to have a graft which is 8 millimeters or more of diameter, depending on the BMI. We have to know that what we propose, what we put instead of the old graft must be 1 or 2 millimeters oversize, and it should be 6 centimeters long or even more. And any graft works for that situation. What do we have on the table? We have hamstrings, patellar tendon, quad tendon, allografts. We have a family grafting, and on the other hand, we have xerografts, artificial grafts, and augmentation devices. When we have a hamstrings, I personally think this is one of the best solutions for the moment. We have a very low morbidity. We have a good healing and excellent mechanical properties. And also, as we heard from Professor Domżalski, it's very appropriate for children. But hamstrings has some disadvantages, which is the possible nerve injury and limited ingrowth. The other choice is patellar tendon, which is also very good and very popular tendon for the graft source for the revision, but it could possibly make the patellar tendon shortening, and it could create a large bone tunnels once put it inside, which might be the advantage that if we have a big bone plaques on the both ends, we can feel the gaps, but it's not appropriate for the younger patients. The quad tendon, personally, I have a very good experience with that because it has all the advantages of the patellar tendon, but has no effect on patellofemoral joint. Allografts, they become more and more popular, but they have decreased healing potential. We know that there's a higher re-rupture rate. We have a possibility of viral transmission risk, which is very important, especially in the younger population. We have also inflammatory response. Personally, I don't like artificial ligaments because there is no healing and there is a very high revision rate. Graft augmentation is something that could be added to every single of the above. And actually, I think it's a good solution. And family grafting, it's mostly popular in Australia and that part of the world. I have no experience with that, so I'm not going to talk about this. And what I said at the beginning, what we do in the revision is strictly directed to what was done in the as an initial graft. And if you look for the geographical prevalence, we have the United States, where still most of the grafts comes from the patellar tendon bone, and Europe, where we have more hamstrings. So my preferred technique, if we have a hamstring as a first choice, of the first reconstruction, I would choose the semitendinosus contralateral, and if it is not possible, I can use the semitendinosus and gracilis. Then I take the patellar bone from the same knee. Then the next one comes is the quad. Allograft is something that I would use at the very, very end, and artificial ligament is something that is hardly to be used. If we have the patellar bone, it's a little bit more difficult because, as I said, we have a bigger hole, both on the tibial and very often even bigger on the femoral side, because we use interference screws to stabilize that. So we must have a graft which is a little bit bigger in size. So that must be double hamstrings or quadriceps tendon. The allograft is also the solution here, and the artificial ligament is just mentioned. Something about the tunnel position. The first on the left, you see that this is the very easy situation, that the tunnel was placed correctly. The very far right is the situation which is also convenient because there is a large difference between what should be done and what was done, and it's very easy to revise. The biggest problem that creates a bigger hole is the middle situation, when there is just overlap of the previous and the graft we have to put. And once we know from the Mars study group that the revision reconstruction generally in over 80% of cases that femoral tunnel is drilled in the entirely new position. We have also the problem of tunnel widening, which is sometimes connected with interference screw, especially those from the previous generation that they were causing the inflammatory response that caused the very large cyst formation. It could be malpositioned graft, and it could be fast and furious rehabilitation. This problem can be solved by patellar tendon bone with large bone blocks with the quad tendon. We can use also the larger size screws, like the oversized screw, just to fill the gap. This is the possibility where the allografts with the large bone blocks could be used also, and the possibility of bone grafting should be considered. So we have to put the patient in a position where we can get the good quality bone grafting. So first think before you start primary ACL, because you might end up with the very, very large hole. We could have the one-stage revision, and this attempt should always be indicated. But in some cases, we should think about two-stage. If we have a poor bone quality for a single stage, if it is not possible to correct graft malposition with the screw or with the graft, or it's just not possible to fill the bone gap, then we have to use the the bone grafting. There is something that I should mention, because as we know, and we will be having that the speech in the a little bit later, that the external extra-articular procedures can reduce the re-rupture rate. So maybe along with the graft we choose for the primary and the second, we should think about something extra-articular, but I'm not going to talk about it anymore. So this ACL story is still ongoing, and this is my personal, I can underline to this, still the primary and revision graft source remains controversial, and we should talk with our patient carefully to consider all the graft options.